Hello, everyone. I am Dr. David Systrom. I am a pulmonary and critical care physician at the Brigham and Women's Hospital and Harvard Medical School. I direct the Advanced Cardiopulmonary Exercise Testing program there, where we've had a major focus on ME/CFS for nearly a decade, and more recently in long COVID. It's a pleasure to lecture to you today. I wish I could be there in person, perhaps another day, and perhaps in the way of an update of some of the things I'll tell you about today. I've been asked by my remote cousin, Jonas Bergquist, to discuss a clinical trial which we have just launched at the Brigham. It's called LIFT. It's a Life Improvement Trial. It's dedicated to ME/CFS patients. It is, as you will see in the course of my presentation, involving two drugs alone or in combination, a prospective randomized clinical trial. There are precious few, as many of you know, in this area, and I'll describe this to you along the way. Many thanks for asking me to tell you about what we're up to. Here's a table of contents of what I'd like to cover over the next 25 minutes or so. The first is to introduce you to the major tool in our armamentarium in investigating exercise intolerance, including ME/CFS, which is the invasive cardiopulmonary exercise test. I'll describe to you how this led us to get into this business. Interestingly, the LIFT trial does not involve that test. It involves a less invasive version of that I'll get to. I'd like to make a case for something we are calling neurovascular dysregulation as a major player contributing to symptoms during acute exercise and perhaps post-exertional malaise in ME/CFS. I will then turn in sequence to the two drugs that we're using as part of the LIFT trial, PTOStigmine, also known as Mestinon. It's an FDA-approved drug for a disease most of our patients don't have. So this is an off-label comment. That's myasthenia gravis. The drug we're comparing it to is low-dose Naltrexone. Many of you may be familiar with, and we'll make a case for using it in this clinical trial and some suggestions about potential mechanisms of action. And then in terms of actual data, we have preliminary data in a study we are calling somewhat tongue-in-cheek Baby Lift. This is a retrospective study of patients with ME/CFS who've been treated with these two drugs, PTOStigmine, low-dose Naltrexone, either alone or in combination, and followed up clinically with a non-invasive cardiopulmonary exercise test. I'll give you a bit of data on that, and then I will describe to you our protocol of the actual LIFT study that we just launched last week after a year of preparation. So to begin, this is the invasive cardiopulmonary exercise test that we perform at the Brigham and Women's Hospital. And I'll point out a few salient features here. Number one, we do incremental cycle ergometry to exhaustion. Having said that, most tests are designed with a ramp protocol to last about 5 or 6 minutes. It's only the last couple of minutes that are intense. Most patients do not realize any form of crash afterwards, for those of you concerned. We like the stationary cycle. The patient is stable. They're able to hold on to the handlebars. We're able to catch them. We don't have to do that very often if there's orthostatic intolerance. The non-invasive portion is shown here. This is a pneumotachograph in this individual's mouth. It measures minute ventilation, breathing, and in addition, expired gas exchange, so we can measure pulmonary gas exchange non-invasively. That's the non-invasive portion hooked up to a medical graphics metabolic cart. The invasive portion one can see here in this gentleman's right internal jugular vein. It's a pulmonary artery catheter. And then the other invasive part is a radial artery catheter in his left wrist. From these, we measure pressures, as you'll see, but we additionally measure both arterial and mixed venous blood gases and other biomarkers that really inform what ails this gentleman during exercise. And I will show you some of the measurements that we make. Here is a relatively simplified algorithm of some of the diagnoses we make, and many of these I will dismiss because they're not really germane to ME/CFS. Occasionally they are in long COVID. Up at the top is the time-honored VO2 peak, or maximum oxygen uptake. This reflects the aerobic machinery of any individual and everything in the interior. That includes heart, lungs, circulation, autonomic nervous system, and even the exercising muscle mitochondrial function. Generally speaking, we have normative values that are dictated by the patient's age and gender and body size. Greater than 80% are predicted we would deem as normal, but I will hasten to add that many of our patients with ME/CFS are mildly affected, at least by this number. Please do not write them off as not having any abnormality if this number is greater than 80% are predicted. But our usual rules are less than 80% are predicted. We will go looking for the abnormality. One other non-invasive measure is the diagnosis of a pulmonary mechanical limit. This means the amount of air that the patient can move per minute is limiting them. This is usually a feature of severe COPD or interstitial lung disease, occasionally respiratory muscle weakness. We measure that by measuring the peak exercise minute ventilation, that's VE, and we compare it to the ability to move air in the resting state, which is the maximum voluntary ventilation derived from an FEV1, that's a spirometric measure at rest. When that number is very high, it means that the patient's ability to move air is limiting them, usually associated with breathlessness or dyspnea. This is not germane to the overwhelming majority of patients with ME/CFS. Every once in a while, somebody with long COVID who was on a ventilator with interstitial lung disease will have one of these. The rest of the world is explained by the Fick principle, which is shown here, and it dictates that the VO2 at any point, but including maximum exercise, is a function of the cardiac output, QC, and the difference between arterial and mixed venous oxygen content. This usually rises about five-fold above resting values at peak exercise, and this difference in content of oxygen in arterial and mixed venous blood rises about threefold normally. And you'll see that these things are where the action is with ME/CFS and related disorders. If we find that the VO2 peak and the cardiac output peak, both of them expressed as a percent predicted, are decreased in a similar fashion, we are entitled to infer that the patient has a central cardiac limit, and we can determine whether they have left heart disease by pulmonary capillary wedge pressure. That's a surrogate for the left atrial pressure that's elevated. That denotes left-sided disease. And we can determine whether it is pulmonary hypertension or pulmonary vascular disease by measuring the mean pulmonary artery pressure, seeing if it's abnormal at peak exercise, and then the resistance of the pulmonary blood vessels at peak exercise. So basically, we can rule out left and right heart disease if the patient has a central pump limit, and that is largely the case in ME/CFS. What we do find most often, and I'm going to drill down on this a bit in a minute, is preload failure. This is down, and the cause is not left or right heart intrinsic disease. It's failure to prime the pump and augment normal filling pressures during upright cycling exercise against gravity. The other side of the universe is over here, and this is a peripheral limit to exercise, and it's most often identified during our type of testing by inability to depress the mixed venous oxygen content. This reflects how well oxygenated blood is getting out to the exercising muscle, and more specifically, a functional mitochondrion, than being taken up and utilized. If there's any abnormality of blood flow where blood is diverted away from the exercising muscle, and that's de facto left to right shunting in the periphery, and or any mitochondrial dysfunction, this number will fail to fall normally at peak exercise, and we can correct it for any degree of anemia. So a little more on all of this as we go. So I'd like to make a case up front here for something we have deemed neurovascular dysregulation during acute exercise, as I've described during the invasive CPET. In ME/CFS, and I'll hasten to add, we've identified similar, if not identical, thing in long COVID as well. We got into this business nearly a decade ago with this paper with Will Oldham shown here leading the charge. This was a combined effort at the Brigham and Mass General. And basically what we did here was identify a cadre of patients referred for our testing because of exercise intolerance. They had shortness of breath, that's dyspnea, but we learned in retrospect they also met many of the IOM, if not all the IOM criteria at the time for ME/CFS. And we could identify in this cadre of patients that we studied no heart or lung disease, no classic reasons for exercise intolerance. And we asked what was wrong with them, what was associated with symptoms. And what we found was something we have called preload failure. It's basically failure to prime the pump. Here's the right atrial pressure. Here's a surrogate for the left atrial pressures. Upright, and I would emphasize if you do this testing supine, lying down, you will miss the signal. And most especially at peak exercise, not at rest on the cycle ergometer. What identified patients without heart and lung disease with impairment of their VO2 peak and symptoms was a depressed filling pressure both on the right side and on the left side at peak exercise, compared to a group of normal individuals we couldn't find anything wrong with. So additionally, we attempted to regress these filling pressures, lower right to left, against the VO2 peak and against the cardiac output peak, and there was an association. So the lower the filling pressures in this group of individuals, the lower the VO2 peak. And the reason by the Fick principle that the VO2 peak seemed to be low, at least in this group, was the cardiac output. So we deemed this preload failure. Again, we found most, if not all, these patients in retrospect had met clinical criteria for ME/CFS. This is where they landed with the preload failure in our algorithm down at the bottom. We took a little deeper dive into this 3 summers ago with the help of Philip Joseph shown here, and we added some notions about pathophysiology that were evolving over time. One was that there is an association with this disorder, preload failure, with something called small fiber autonomic neuropathy. I'll explain more in a second. The other is there is a subset of patients who have an additional vascular abnormality in addition to the preload failure. So here we borrowed, and this was the study design, from the POTS literature with the upright tilt table test, that's postural orthostatic tachycardia syndrome, where others in the field, in that field, had identified a low flow group during an upright tilt table test and a high flow group. So we created tertiles of blood flow versus VO2. It's known that normally, and this was a normal group of patients or individuals who had exertional complaints in whom we could find no abnormality, normally the slope of cardiac output versus VO2 during incremental cycling is about 5 to 6 ml per ml. And by definition, with tertiles, there was that middle group. This was the low flow group. They had a low cardiac output versus VO2, a low cardiac output at peak exercise, and relatively normal oxygen extraction. What got our attention, though, was this a high flow group. Remember what we're measuring with cardiac outputs, 4 cardiac outputs with the Fick principle, with our type of testing, is pulmonary blood flow. So we're measuring VO2 at the mouth, and then we're measuring every minute arterial and mixed venous oxygen content and deriving a Fick cardiac output that is de facto pulmonary blood flow. So these folks had a lot of pulmonary blood flow, and additionally, they had poor oxygen extraction, disproportionately so compared to the other 3 groups here, the normals and the 2 patients, the 2 groups of patients with preload failure with lower flow. So poor oxygen extraction and a lot of pulmonary blood flow, these are hallmarks in the cardiology literature of left to right shunting. through things like a septal defect in, between the atria in the heart. But none of these patients had septal defects. We know that from both cardiac echo and special measurements during the resting right heart catheterization. So we believe this represents, at least to a degree, peripheral left to right shunting, blood flow not going where it should during exercise to the periphery. Additionally, a large percentage of these patients had skin biopsies for small fiber neuropathy. In the blue here, darker and lighter, we show definite and probable small fiber neuropathy based on the neurite density in the epidermis of the skin. This was a single biopsy above the ankle. The total number ends up about 44% of patients have definite or probable small fiber neuropathy, a frighteningly close prevalence to that described previously in things like fibromyalgia, associated disease, and postural orthostatic tachycardia syndrome. So with this information, this is where these patients land in our algorithm. They have both preload failure, and then this subset of patients we have learned more lately are largely female sex, have this high flow phenotype with evidence of peripheral left to right shunting and failure to extract oxygen normally. So a double whammy, as it were, with failure to prime the pump, but additionally failure to divert oxygenated blood properly to the exercising muscle mitochondrion. So our interim conclusion based on these studies that I've shown you is that in ME/CFS, exercise intolerance is related to systemic vascular dysregulation, both preload failure, which seems to be ubiquitous, but additionally in a subset of patients, evidence of peripheral left to right shunting. And because of the high prevalence of small fiber neuropathy, our interim conclusion is that neurovascular dysregulation ails these patients and is associated with symptoms during exercise in such patients. All right, a little bit on the two drugs that we're using in the LIFT trial. First is PTOStigmine, and I wanted to tell you how we think this works. There is a well-documented neural pathway out of the central nervous system to the sympathetic ganglion and a cholinergic step, which would be augmented by PTOStigmine, which retards the breakdown of acetylcholine in any synapse, but including presumably the autonomic ganglion. And I'd like to remind everybody that the outflow from the sympathetic ganglion is truly sympathetic, and these adrenergic fibers envelop blood vessels where they beget blood vessel tone and therefore help with the autonomic nervous system regulation of blood flow. So we think PTOStigmine is working right here and ultimately helps with blood vessel tone and function. We did a prospective randomized clinical trial in roughly 50 women with ME/CFS. These patients were sent to us. They underwent the clinical invasive cardiopulmonary exercise test. We identified preload failure, and they were randomized to receive a single dose of PTOStigmine, 60 milligrams by mouth, or placebo, and then they would cycle again with the existing catheters in place 45 minutes later. We asked the question, is there any evidence, even with a single low dose of PTOStigmine, that we affect favorably vascular dysregulation? The answer seemed to be yes. The effect size was small, but this is what we saw. The VO2 peak was augmented versus the initial cycling VO2 peak if they got drug, and it actually worsened if they did not. I think this may be the beginnings, perhaps, of post-exertional malaise with placebo. And the reason the VO2 peak was higher was cardiac output was higher. It was actually lower if they got placebo. And the reason the cardiac output was higher was the filling pressures appeared to be higher if they got drug, actually lower, worse if they did not. So we think this helps us with the notion of neurovascular dysregulation as the pathophysiology of at least part of the symptoms with exercise, and that it can be helped with PTOStigmine. quick overview of potential mechanisms of action of low-dose naltrexone, which many in the audience have likely used in patients with ME and perhaps long COVID. And this is a little summary of how it's thought to work. It's a mu-opioid receptor antagonist. In high doses, it's used for alcohol or opioid use disorder. In low doses, about 1/10 of this FDA-approved indication. It's probably a different animal. It does not immunosuppress the patient. In fact, we know from workers at the Griffith in Australia, natural killer cell function is actually restored in ME/CFS, and at the same time, it antagonizes inflammation through tamping down the toll-like receptor number 4 through the NF-kappa B pathway, and mitigates the production of pro-inflammatory cytokines, including TNF-alpha and IL-6. There is precious little in the way of randomized clinical trials out there currently. There are some descriptions with open label of self-description of improvement of pain with low-dose naltrexone and fibromyalgia, and then an ME/CFS. A start in this business, a retrospective chart review in Finland, where self-reported responses of all symptoms, including fatigue and alertness, brain fog, were improved. But again, open label and a retrospective study. All right, here's our first stab at all of this. This is a retrospective study as well. This is patients with ME/CFS who've been followed in our clinic at the Brigham and Harvard Medical School for at least a year, receiving either Mestinon, PTOStigmine, or low-dose naltrexone, or the combination. And we had a comparator group who received no drugs, and again, over about a year. And what we looked at was, as an endpoint, was something called a SHAPE study. And this is part of the big lift study I'll come back to. It's a non-invasive 3-minute step test, upright, hand-holding. It does not, in general, elicit any post-exertional malaise. It's a quick test, it's self-paced, and even those with orthostatic intolerance are able to hang on and do this study. So the metabolic cart gives us many of the same numbers that we get from the non-invasive cycle ergometry metabolic cart test. And you'll see so 2 of our exercise physiologists showing us what happens with the SHAPE test. All right, so with the SHAPE test, one of the key physiologic variables that we get is the 1-minute heart rate recovery, and that's shown over here. These are the patients treated with LDN, low-dose naltrexone monotherapy. Note, please, the low number. Those treated with PTOStigmine monotherapy, 78 patients. A comparator group, you'll notice heart rate recovery up is good. These patients were better at baseline, and that's probably a reason that they didn't get medications. So not certain how useful the comparator group will be here. But what's of some interest, I think, is that with PTOStigmine, either alone or in combination with low-dose naltrexone, there appeared to be improvement over about a year in these patients, the majority of them, of heart rate recovery, which is thought to reflect parasympathetic tone and aerobic fitness. So with this in mind, we have designed and worked for a year on getting all the regulatory pathways in place, the LIFT study. And I wanted to give you the outline of this. Also wanted to share the exciting news that we enrolled our first patient 1 week ago, and our number 2 will be tomorrow morning. So this is the design. Special call out to Johanna Squires, who's helped organize most of this. We are recruiting patients from the Brigham and from Mass General and from the Open Medicine Foundation Study ME Registry. They get screened in. There will be 40 patients in each of the 4 arms for a total of 160 patients. We project we'll be able to get this completed over a year or 2. The 4 treatment arms are as follows: the combination of Mestinon and low-dose naltrexone, Mestinon plus placebo, low-dose naltrexone plus placebo, and then finally full-blown placebo. And we will study them over 3 months with a follow-up visit. here's their screening at the onset. Everybody's going to meet the Canadian consensus criteria for ME/CFS. We are excluding those who've had the onset of their symptoms after the pandemic. So this is a true focus on ME/CFS. They have to have a smartphone, and we are preferring treatment-naive patients. We'll see where that goes with recruitment and some exclusions down here. These are the two drugs that we're using. This ultimate dose will be 4.5 milligrams per day, and this will be 60 milligrams 3 times a day, ultimately with a step-up protocol and the ability to scale back if we need to. One of the outcomes will be measured with wearable devices. This is the Garmin VivoSmart. We have a fabulous computational group who will be monitoring all these things online in real time throughout the 3 months. We will be measuring at baseline and completion urine and blood, 4 well-validated questionnaires, again, flowing through online, and our computational group. We will be sending biomarkers for proteomics to SomaLogic, metabolomics, and transcriptomics to Elaine Moreau in the University of Montreal, peripheral blood mononuclear cells to Maureen Hansen at Cornell. And then every 2 weeks, we will be repeating the questionnaires, and this is where we will end up. I wanted to quickly add a little addendum, which is we have increasingly recognized with our own work and the work of colleagues in Amsterdam, Dr. Woest et al., that another reason for this high flow or apparent extraction problem group is intrinsic mitochondrial dysfunction of the exercising skeletal muscle. So we are actively under discussion with Amsterdam about sending them frozen muscle biopsy samples for what you see here, a whole array of interrogation into structure and function of the skeletal muscle and the mitochondria, and both innervation and vascular supply. So this is under discussion and may well become part of the LIFT protocol. So that's all I have to tell you. I want to do a special call out again to Johanna Squires and Shreya Palwaye, who is pre-med working with Johanna, our computational group headed up by Wenzong, known to many of you, I think, Maureen Hansen at Cornell, Jonas in Sweden, my distant cousin, Elaine Moreau in Montreal, Ron Davis in Stanford, and then Linda Tannenbaum and Danielle Meadows, who commandeer OMF, where the funding is coming from for all of this. And I thank them, and I thank you for my attention, and I'll close there.